you for joining us this Sunday evening. I hope everyone had a good weekend and is ready for the new week, or if not yet, at least getting there. We've been doing these weekly live streams talking about mainly about cataract surgery, but I've gotten some requests to talk about mixed procedures, and so that's what we're going to do today. We're still going to talk about cataract surgery. I'll show a case of cataract surgery combined with the Hydrus stent, and we'll really focus on the Hydrus stent today as far as the mixed procedures. If you have any questions, I'll try to look at the chats as well, and we'll try and answer those in real time. So please send in your questions and comments as well. Just want to give a few minutes here for all the different platforms to be up, and just making sure that we're up on all different platforms. Let's see here. I think we're good. Okay, fantastic. All right, let's go to our first video. All right, so this is a video of cataract surgery combined with MIGS. This is an unedited video, and I think where feasible, I'll try and show unedited videos more in real time. That way, it's more, hopefully, just more instructive for beginning surgeons. Let's see. I'm going to fast forward in this video a little bit. I think we spent some time setting up focus here, so we should be ready to go. All right. So I start out my cataract surgery by making a paracentesis incision for my left hand. I use just a cotton tip sponge to stabilize the globe, and then I use preservative-free lidocaine to achieve intraocular anesthesia as well as anesthesia on the ocular surface. And then I'm injecting a dispersive viscoelastic to maintain the anterior chamber. This patient has what we call a Christmas tree cataract. It's kind of hard to appreciate here, but basically those particles that you see here inferiorly are birefringent, which means under the slit lamp they actually look red and green, and it's I'm not sure of the clinical significance of it, but it is something nice to note at the slit lamp. I make my incision with a 2.4 millimeter keratome blade, and then I use cystotome to begin my capsulorhexis incision. I use a cross-action Entrada forceps to continue the capsulorhexis, and we continue the capsulorhexis in a curvilinear fashion. And then the next step, you notice throughout this whole procedure that I'm stabilizing the globe with a 0.12 at the paracentesis. I think whatever technique you use, it's important to be able to stabilize the globe and minimize the risk of having a problem if the patient moves their eyes or looks right and left. For the hydrodissection, another important point is to tent up the anterior capsule so you get a good cortical cleavage hydrodissection, which separates out the cortical material from the capsule. And then I also do hydrodelineation one time. I don't spend a lot of time trying to rotate the nucleus. For the most part, I found that using the phaco chop technique, I usually am able to get pretty good rotation most of the time. So I start out with phaco, and I core out I phaco out a central core, and then I use a second instrument to do our chop maneuver. And you can see pretty quickly we already have the first quadrant out. I found this technique to be very efficient as far as the progression of the cataract surgery, eliminating unnecessary movements. We're already working on our second quadrant here. And you can see, even though I didn't spend a lot of time rotating the lens, it did rotate fairly quickly and fairly easily. Here, as we get to our last quadrant, I'm using my second instrument to prevent the posterior capsule from coming forward. And you can see we got the rest of the nuclear material there. That is the epinuclear shell that's still left. And so we'll be removing that here. I use my second instrument to kind of turn it around, but also to protect the posterior capsule. I'll just go to the side port incision, make sure there's no nuclear fragments there, and then we'll come out. So you can see that there's still some cortical material present sub-incisionally, and we'll go in there now with the irrigation aspiration and remove that as well. I use BSS during this time while my scrub tech is getting the IA ready. I'll go in with BSS and just irrigate out the paracentesis, make sure there's no nuclear material or no pieces still left there. And then I go in with a silicone tipped IA and we remove the remaining cortical material there sub-incisionally. I like to grasp it and then I like to go ahead and just pull towards the center. All right. Fantastic. So a little bit off the screen here, but basically what we're doing is we're polishing underneath the anterior capsule. And we're removing any cortical material that may be present in the capsular fornix, trying to achieve, trying to leave as, preferably not leave any cortical material present. And here I'm using the back of the IA handpiece to polish the posterior capsule. I use this Terry squeegee or silicone tip capsule polisher as well, just to remove any kind of cortical material that may be still attached centrally. I started doing this routinely in all cases. I think it's just a nice technique to kind of polish the central posterior capsule. It doesn't take that long to do, and it gives us a nicer looking, cleaner case. Here I'm injecting a viscoelastic. I think I'm using Amvisc or Anacavisc at this point because it is a mixed case. And then I'm injecting my single piece acrylic, hydrophobic acrylic into the capsular bag. I use a Lester forceps here just to make sure that the IOL is completely in the capsular bag, and I rotate it usually about 90 degrees or so. And then I'm going to, since this is a mixed case, I'll inject, MIGS obviously stands for minimally invasive glaucoma surgery. The Hydrus device is a MIGS device. And so what I'm doing here is basically injecting more viscoelastic to pressurize the anterior chamber. And then this is a very important step. I'm making a second paracentesis on the right-hand side, and this is where the Hydrus device is going to go. Now and then I put Viscoat on the corneal surface to provide us a nice clear view, and that's our coupling agent. During what's happening now is this is often edited out in our videos that we post on YouTube, but basically we're just rotating the scope. We're cutting the tape from around the patient's head so we can rotate the patient's head away from us, and then we'll proceed with the Hydrus placement. That second incision that I made at the paracentesis, I would try initially to get away without doing that and just place the Hydrus device through the main wound. And I found, yes, I was able to do it. It was sometimes more difficult, and I'd struggle a little bit more to do it, and sometimes we wouldn't get a good placement and good alignment. So I think it is worthwhile to go ahead and make that second incision, which allows just the angle of approach for the Hydrus to be more in line with the natural anatomy. So I do that now for all my Hydrus procedures. The Hydrus is approved to be done in conjunction with cataract surgery, and so this is done, as you can see in this case, it's done in conjunction with cataract surgery. So before I go in, I like to rotate a because you can rotate the tip of this. I like to rotate it so it's pointing up. I like to use a little roller to roll the Hydrus device forward, and we know it's right at the tip. So that way, when I engage the trabecular meshwork, we're right there and we're ready to go. So I place the Hydrus device into the anterior chamber through the new incision we created. I take my gonio lens, and under direct visualization now we're looking at the nasal angle. We have to identify, obviously, our landmarks. We have to identify the trabecular meshwork, and then we incise the trabecular meshwork with the Hydrus cannula. It's got a sharp edge, and we can see here that we're making progress. We're incising the trabecular meshwork. We're pushing back posteriorly to create that space so that the Hydrus device can go directly into Schlemm's canal. And there we see a nice smooth placement. At this point in time, what I'm doing is I'm pushing back on the Hydrus device, and I'm trying to see if I can advance it a little bit more. But I think I'm actually happy with where that Hydrus device is sitting. We'd like to see the TM kind of halfway, or maybe a little bit more past halfway, in a little groove there in the Hydrus device. Here I'm confident of the placement just because of the way it went in, but I'm trying to see if I can get a view of more of it, more of the Hydrus device. I've routinely checked the position of the distal tip at 1 week post-op. I want to just document in the chart that the distal tip is in good position and that the Hydrus device is well placed in the anterior chamber, in Schlemm's canal. One of the things that can happen, all we're doing here right now in this part of the procedure is we're just rotating the patient's head back, we're irrigating off the viscoelastic, and we're rotating the scope back. But what I was saying is I like to document that the Hydrus device is in good position, and I look at the distal tip to make sure that it is inside Schlemm's canal. The Hydrus device, when you're first starting out, can sometimes dive posteriorly, and so we want to avoid that, because then, you know, it will probably still function okay, but you're not getting the full mechanism of all the mechanisms of action of the Hydrus device. So we're just continuing our cataract surgery. We've already got the IOL in place. We're using irrigation aspiration. We remove the viscoelastic from behind the lens, and then we remove the viscoelastic from the anterior chamber as well. And we're rotating here the IOL, freeing up any cortical material that may still be present. And so we're proceeding in that way. Let's see. Okay, so we're just going through removing the viscoelastic, and now we're going to, I like what I'm seeing. The lens is well positioned. The patient's head is no longer taped, so you'll see there's some more movement there. And then we'll just hydrate the main wound here. And then we'll inject. I like to check the pressure in the anterior chamber just with the back of the cannula, and then we're going to use a wet cell sponge to check all the wounds. Okay, and that's, I think that's the entire case, and here we're just removing the lid speculum, and we're done with the case. Okay, so that's that's the cataract surgery combined with the Hydrus device. Obviously, it doesn't always go as smoothly as that, and sometimes you have to struggle a little bit to get the Hydrus in position, but for the most part, the more experience you get with this, the more readily the Hydrus device goes into position, and then if it's not going to go into position, you'll also be able to more readily identify that. I think it's important to be as comfortable with as many mixed procedures, to be comfortable with several mixed procedures, because they don't always apply in the same patient population. and different mix procedures are better in different situations. And that's something we can talk about as well, if people have questions about that also. Okay, so let's go ahead and see if we can pull up another video of of a Hydrus placement. Let's see here. All right. Okay, so all right, so this is another Hydrus case, which I looked at, and basically it looks like we've already placed viscoat on the corneal surface, and we're getting ready to place the Hydrus in the anterior chamber. Once again, I rotate the Hydrus tip superiorly, and I advance the Hydrus tip just to the very tip of the cannula. Sometimes it can be further back initially, and so you want to get it to the tip of the cannula. So once you get into the eye, as you start rolling the dial forward, it comes right out. It comes right out. So let's see if if this video has a little bit better focus here. There's some bubbles in the anterior chamber, which can sometimes obscure your view. And we're once again incising the trabecular meshwork going into Schlemm's canal. And I'm liking what I see here so far. I'm pushing up and pushing back. And here we advance the Hydrus device. It looks like it's a little bit superficial there. I could see too much of the device. It wasn't really behind the trabecular meshwork. So we're going to re-engage again, and I'm going to apply a little bit of posterior pressure here, create a potential space for the Hydrus device to go into. Let's see here. So that looks a little bit better. I can see it behind trabecular meshwork, but it looks like I'm not really too happy with that as well. So we're being patient. We're just getting reoriented, improving our view. I actually go into a different part of the angle here. And it's hard to see because that air bubble is right there, but I'm happier with that placement. You can see the windows as they advance into Schlemm's canal, that it's behind the trabecular meshwork. It's no longer superficial. The tip is further out, and so what we're going to do is push back on the tip and advance it. And you can see that it advances nicely. There is a little groove there in the Hydrus device. Well, so it's already gone, but let's see if we can go back and see that again. There is a little groove there in the Hydrus device. Let's see if I can pause this video. Kind of right here, and you want the trabecular meshwork to be kind of halfway up the neck of that device. That's where you want it to be. So that's placement of another Hydrus device. Once again, we're going back into the primary position, and we're going to do irrigation aspiration. Let's see if I can pull up another example of a Hydrus device for you. And we're doing all these Hydruses just because one of our viewers had asked to see the Hydrus. So if you have any requests for things you'd like to see, please let me know. Okay, so let's see if we got another one here. Okay, so we're going to start this rolling. Part of the beauty of live streaming is that it's live, and so although at some point in time I've marked these videos as good, I'm not exactly sure what it is we're going to see here, but it looks like we're already in Schlem's Canal, and it looks like we're already advancing the Hydrus. Okay, let's go back and just see a little more. Let's just go back and see that again. Okay, so we're already in Schlem's Canal. We've already created our secondary incision. We've already incised the anterior trabecular meshwork, the anterior wall of trabecular meshwork, and we're already into Schlem's Canal. And so here we're going to start advancing the dial and start advancing the Hydrus device into Schlem's Canal. And we see there, that's what you want to see. You want to be able to see the windows, but they're kind of covered by the trabecular meshwork. And then you want to slide back on the inserter. And then I like to engage the inserter, push back, and then advance it a little bit more forward. And you see where that groove is. Let's see if I can show you that. You see where that groove is kind of sitting outside, halfway out into the anterior chamber and more than halfway covered by Schlem's Canal, covered by the anterior trabecular meshwork. In this placement of the Hydrus device, you can see the patient is under topical anesthesia, the eye is moving, and that's one of the challenges of doing these procedures. Okay, so we're happy with that placement. Very good. Okay, so that's really about it for the Hydrus devices. I'm not able to see the chat on Facebook for some reason. Here we go. You know, any cortical material that may still be present. All right, I'm seeing it now. All right, fantastic. Let's see here if we can mute this. All right, excellent. So I'm going to show one more video of actually, I think that's probably good for today. Today, we've gone over. I don't like to keep these too long. I like to keep it informative and educational. I have a few other interesting cases we could show, but I'm going to save that for another time. I'll plan on doing these weekly. If you have requests for what you'd like to see, please let me know. I want to thank you, those of you who tuned in. If you're a practicing surgeon, I hope you found this useful. If you're in training, I hope you found this useful. And if you just stop by to support, we appreciate that too. All right, thank you all. I look forward to chatting with you again. Bye.